Hello and welcome. Thank you all for joining us this evening. Today we will talk about COVID-19, U.S. health inequities, and the long reach of history. Professor Evelynn Hammonds and Nancy Krieger will engage in a conversation moderated by Professor Michael Jeffries, focusing on the intertwined sociopolitical and socioeconomic drivers of racialized health inequities during the COVID-19 pandemic. This talk will draw on the professor's distinct and overlapping expertise in relation to history of science, social epidemiology, and a shared commitment to understanding and addressing societal health inequities from the past to the present. Michael, the virtual floor is yours.
Thanks so much for that introduction, and thanks to everyone joining the call. It's really a pleasure to be in conversation with you, Evelynn and Nancy. And I think the place I'd really like to start is just by asking you to give us a little bit of the historical context for the coronavirus pandemic. Certainly, there have to be some reference points we can look to through global history to understand what's going on today. So if you could give us that foundation for our conversation, I think that would be a great place to start. Evelynn, would you mind taking the first swing at it?
No, I don't mind. Thank you, Michael. And thanks also for that really wonderful introduction. I think looking at this, what happened with COVID over this last really very long and difficult period of time we've been going through, I think some of the things that I always have to begin with as a historian of science and medicine is that pandemics don't create inequalities, they reveal them. And that is exactly what COVID has done. The existing inequalities within the United States with respect to this health status of many, many people has shown that we have deep inequalities in this country, that they are historical, they have persisted over long periods of time, specifically if you talk about groups of African Americans, other people of color, poor folks. This is something that has been a striking feature of US life since its earliest, the earliest moments of the Republic. And so what COVID brought to us is just ripped off the cover of all those inequalities that many people have not wanted to address and that we've not sufficiently addressed as a nation. So it reveals inequalities. Those inequalities speak to issues related to jobs, to education, to almost every aspect of American culture. And that's what I think we've seen right away. And for me, what started happening right after we realized we were in a pandemic is that nothing was a surprise to me. I expected poor people to be suffering from it earlier. I expected people who only get their health insurance from their employers to be taking a big hit from COVID. I expected people who worked in certain kinds of public-facing jobs, people who lived in multi-generational family situations, and all of that. This was going to strike them hard. There was no question in my mind, just based on what many, many other outbreaks of infectious diseases has already shown us. We tend to forget those lessons, what we learned from those other outbreaks. And so other people were surprised, but as a historian, there was no way I was surprised.
Thank you for that. Nancy, do you want to speak to the history a little bit? Other examples that we can look to that inform what we're going through today?
Well, one, I just want to endorse everything that Evelynn has said. And as a social epidemiologist, we weren't surprised to see the inequities. What was a bit surprising, and it ties back to things that have happened in prior epidemics, is who's managing the information, who's managing the data, what data are shared, made public, and what data are suppressed and not shared. So who knows what's going on? So there were always problems with getting good data in earlier times, not just because of technical issues. Obviously, in prior pandemics in the early 1900s, nobody had a computer. They had a Hollerith machine to process lots of punch cards, but they didn't have a computer as we have it now. You would rely on the telegraph for fast communication. You would not even have had a telephone. So, but those are about the technical aspects of data collection. What matters is who's counted and who isn't. Who's counted among cases, who counts as being a case, who is diagnosed properly to be a case. There's a continuity of that. And at the same time, it's also surprising how absolutely terrible the data were at the beginning of the pandemic, and in many ways continue to be on the social aspects of the pandemic. And data collected from individuals, and we'll get into that more. So I think There's also a continuity of not only what is the real problem in the real world that is playing out in people's physical spaces and in their bodies and in their health, but also what representation of that is there in the health data systems and that are available to the public to actually understand how to respond.
Since you mentioned it, can we stick on this point about data collection? Because the way you described it is really concerning. I mean, clearly you can hear it in your voice, right? How disturbing it is for you that we are where we are when it comes to data collection and reporting. Can you unpack that for those of us who are a little bit distant for us? What are some of the problems that strike you as most pressing right now? Or maybe we're starting to correct them, but have been major issues in that realm of the pandemic. Can you just help us understand that a little bit more for those of us?
Yeah, I'll say it really briefly because I also would love to hear what Evelynn has to say about this. One, there are being corrections made. And since the new administration has come in and there's a health equity task force that's focused specifically on COVID-19, there are improvements in how CDC is reporting data, and state data dashboards are also reporting data. The data come from what people submitted for tests. They come from what people got diagnosed as whether they had COVID or not, and they come from death certificates. What's been pretty astounding for the first part of the pandemic was that everything in the US and health records is racialized. Mm-hmm. It's hard to find a health outcome in this country that you don't find data where people are categorized with an erroneous notion of innate individual race as opposed to having to live in socially constructed categories that have biological consequences. For COVID, good luck. At the beginning of the pandemic, there was no data on race ethnicity. There was citizen science, there was data journalists, but like official data to get that from data dashboards, and it's still not so great. I mean, it's much better. Now you have like the mortality data are just now about complete, but for a good part of last year, like it was missing on most deaths, the death data that's being reported. It's a standard element on the death certificate since like the death certificate got invented. Mm-hmm. Completely bizarre. The other thing that remains a consistent absence, which is, this gets back to the points that Evelynn was making before, we know in advance that there will be health inequities. Therefore, you want data not only on race, ethnicity, but you want to have the social context around that, that's socioeconomic as tied to racial discrimination. Mm-hmm. Zero socioeconomic data reported on COVID. You know, doing my team, we were doing the geocoding as quickly as we could to try to look at data in relation to zip code and county to bring in those kinds of metrics because it wasn't being done by the health agencies. Wow. And that used to be a major gap. And then even you would think by the time the vaccination happened, and it's like the moment a vaccine was being developed, everyone knows you're going to need to like have a data form. The data form existed. The data forms, you looked at the page that was like a third of the page had questions about race, ethnicity. The first report of who got vaccinated was missing for like almost everybody. Yeah. So that it was on the form, but it didn't happen. And you know, and similarly, Ayanna Pressley and others in Congress put forward a mandate in June that the data had to be reported. And then guess what? It wasn't. Like as of August, it was supposed to be. And then we checked the data and guess what? Still missing. So I think that's the context that we're talking about. And do not have clear data on the sense of the inequities and how they're changing. Because the pandemic rolled across the country, you had variation in the extent of the racial ethnic inequities because of the different geographic distribution of this country, of the population as tied to histories of enslavement, Jim Crow, and much else.
Right. So I would add, I mean, I think this is one of the fundamental issues that came out as Nancy just expertly described. One of the things that I noticed is by June, when Ayanna Pressley and Elizabeth Warren and the congressional folks got on in the media, and they said, we need to have better data on race, ethnicity, and as well as sex and other issues. And people were saying it as if this was the first time this question was being raised. But what was a real surprise is none of us who actually think about this stuff all the time didn't even realize how broken the system was. Mm-hmm. My expectation was that states were uploading their data to CDC, and it was going into that we were going to be getting the stream out of CDC with all the boxes checked, and that did not happen. It also showed that our systems it really was one of those moments that showed the deep level of fragmentation in our system. States were still collecting data differently I mean, I thought by this point it was all pretty uniform. It's not going to be like what I look at in the papers in the basement of the Countway Medical Library, where every state got a different little form. I thought those days were over, but it turns out they were not over. And so to have a call like that from Congress people to ask for data on race and ethnicity, and then the other kinds of data that Nancy referred to, was an absolute shock. And that it still not fixed completely. So there's some serious systemic problems here in the way our public health, quote unquote, the public health system, that for me includes, federal agencies, state agencies, and all the way down to the community levels. They differ by state to state, and sometimes in very, very profound ways. So the picture that you need to make effective policy to bring this thing under control, we didn't have for so long.
Right. Well, as I said, that's pretty eye-opening. So thanks to each of you for explaining it. You've already both talked about the sort of predictability of the racial disparities that we've seen in the ways that sickness and death have played out as a result of this pandemic. Can you just tell us, so we're all on the same page, what are the reasons that people of color are getting sicker and dying at higher rates? And as much as we can rely on the data we have, why are the inequities playing out the way that they are, right? You knew it would happen and it's happening, but I just want to make sure everyone's on the same page about why. Evelynn, could you start us off?
Yeah, I mean, the way I've been trying to answer that question, it's a very broad historical question. The historical roots are, they're not simple, but just to talk about a couple of points that you really have to understand why the disparities that certainly African-American peoples have suffered, health disparities that they have suffered since the beginning of slavery. So I'll leave slavery out of it. I'll start at the end of slavery. When the enslaved were finally free, what many people don't realize in the late 1860s, there were many outbreaks there were several major outbreaks of disease, including smallpox and cholera. At that moment, when the newly freed African Americans had nothing, right? No hospitals, no very few trained medical professionals, no housing, no jobs. It was the end of slavery, and they walking into freedom, they walked into a crisis of healthcare at that very moment. And what the next years after the end of the Civil War were about, Black communities trying to reestablish themselves, to find work, to start building their communities, to get themselves educated. At the same time, medicine, the practice of medicine writ large in the United States and public health is also an important inflection point. But this whole system is then fundamentally racialized at that very moment. Black people had nothing. They're trying to build up institutions to take care of themselves. They weren't getting a lot of support from private philanthropy, from federal government. In fact, Jim Downs, who writes about this, and his book is called Sick from Freedom, talks about the fact in the period of Reconstruction, African Americans who were trying to figure out how are we going to live, how are we going to become, take up our full citizenship, was one of the first groups who said, well, now that we're citizens, the federal government ought to provide us some health care. Mm-hmm. And because that's the only way we're really going to get it right now. It didn't happen. I mean, it happened for a very short period of time. And then the federal government pulled back and said the states have to provide this kind of care. And the states, particularly the states of the old Confederacy, did not do that. So we're talking about African Americans as a group at that time were in a very different trajectory than even if you make the big comparison between African Americans as a group and white Americans as a group, and that's very complicated. But African Americans were at a distinct disadvantage right then. Mm-hmm. So think about by 1918, what do you expect to see? There's now, at least by 1918 in the influenza epidemic, there's a small but growing Black medical professional class. There's a few Black nurses that go to a few training schools. Black physicians are not allowed in the AMA. Black nurses aren't allowed into the nursing associations. There are very few Black hospitals. Black communities are still trying to build a health infrastructure for their own communities. There's a great deal of structural, de facto, outright segregation. And those practices at the beginning of the 20th century, in that situation I've just tried to characterize, you can see Black peoples were at a very distinct disadvantage in terms of getting appropriate healthcare, and certainly not at the level of healthcare that many white Americans were able to get. And that just goes through the 20th century.
Yep. Thank you.
You come to this point, and it's going to be a difficult situation. And Nancy can add to that as well.
Absolutely, Nancy, you want to jump in?
Yeah, and to build on what Evelynn is saying, and to bring out some other points. The first question is who got exposed? Because you're not going to get sick if you don't get exposed. So there were already pre-existing health inequities, particularly around cardiometabolic diseases, and there's already pre-existing premature mortality among particularly African Americans and also American Indian Alaska Natives. And this has two big implications for the pandemic. First, who's exposed? And what happened with who had to go to work and be in public facing jobs and had to go in transportation and get to work versus could stay at home. So there's a huge part that increases the risk because of who was doing the kinds of jobs that required, which is a lot of people, by the way, required people like 75% of the workforce, even though you only heard all the time about the people working remotely at home, who were actually in face-to-face contact with, mind you, no OSHA guidelines. To date, last month, the Biden administration finally put in a temporary emergency standard for OSHA's guidelines for healthcare workers only, not for any other kinds of workers. That was one of the things that was being pushed. So there's no workplace regulation. And this is something that is an incredibly airborne disease. That's what we learned. I mean, yes, at the beginning, back to Evelynn's point, there was uncertainty about whether there was need, is it transmitted by people touching things or touching surfaces or touching each other? It's really clear it's the aerosol in the air, but that you have to learn over time, and that there was asymptomatic transmission, which you also have to learn. So the first thing is exposure. But then if you're exposed, what happens? Do you have access to testing? So you even can figure out whether you're going to be endangering people that you love and your family, whether you would need to self-isolate. How are you going to know? Because again, you could be asymptomatic and be transmitting and not know. Second, if you are at home, who has the space to self-isolate? Who has extra room? Who is living not alone, but able to do that? That was a huge issue. So then you end up with, and also to the point of the multi-generational households that everyone was referring to, that you have then more people getting exposed. Then you have, if you got exposed and you got infected and you get sick, does it matter if you're already got other various chronic diseases happening? The answer is yes. But what happened is a lot of the conventional literature just wanted to blame the increased severity of sickness on those people had bad health habits. They already had bad health, so they're bad health habits, not understanding the social structuring of what drives rates of diabetes, what drives rates of cardiometabolic diseases, cancer, et cetera. And then if you got sick, did you get access to the hospital or not? And did you get decent care or not? And then the last thing to say is that the variation, the inequities, not variation, actually have been greatest at the ages of working age adults. Because what also happens is because of premature mortality due to health inequities, a lot of the people that were in the nursing homes, they're disproportionately white elderly people because they're the ones that lived that long. And they were very vulnerable to dying because of bad practices involving the labor regulation and the exposure regulation at the nursing homes. So it's really important to pull all the different pieces of the puzzle together to understand who was at risk and placed at risk of exposure, because the basic point is no exposure, you don't get sick.
Right.
And that's the fundamental public health prevention standpoint. It is out now in terms of who's going to get the vaccine and how.
Yes.
Yeah. I mean, thank you for breaking it down. And we've been talking about, so many of the challenges, and these are deep-seated historical challenges that we're seeing play out right now. And I wonder if we could sort of broaden the lens and look not only at the challenges, but I wanted to ask you if you see any places where the United States is meeting some of the challenges that it faces, right? Are there things that the country is doing well, both within our borders and as a sort of as a broader contributor to the global community that's really in this pandemic together? Are there places that you see us doing well versus places that you see us doing not as well, both domestically and globally? Nancy, would you like to start there?
I mean, I think one thing with that question that's complicated is it depends when in the pandemic. What were people doing in the very early stages that went completely off the rails in the United States, given the administration and its denial of the pandemic? And then where have there been better actions taken, particularly as some of the work has improved on the community-based aspect vis-a-vis some of the vaccination work, but not enough of it with the move towards health equity. So it's just like the pandemic is very dynamic, it's not one thing.
Yeah.
And it's changing, and the virus itself is changing with the new variants. So is the response. I think, just rooting to the present, I think one of the things that's just really striking about what I think we can expect to see, building off of what happened with this pandemic that is possibly more extreme, I'd be curious what Evelynn thinks about this and others, is that there's now two very different groups that are not vaccinated. There continue to be the groups around what I would understand as health inequities who have still not gotten good access to vaccine because they don't get paid time off from work. They don't have paid sick leave from work in case they don't feel well after they got the vaccine. The vaccine has not been physically accessible to them. It's not been brought to their communities, as well as also the many issues which Evelynn has written about and can speak to, about questions about the distrust that comes from maltreatment by medical institutions with long histories of racism. But the other part is completely about the politicization in utterly ideological terms. Yeah. So that right now you're seeing like the least vaccination in the quote unquote most red states, meaning geared towards the views of the ex-president. And so that's really worrisome because not all those people are in the same category. They have access to the vaccine, right? Refusing to take it. And those can't be conflated. Because where the country really needs to step up is in the better information, yes, that can be accessible to groups, including people that have very different political points of view, but that has to be put in the frame of making sure that people that still lack access get access.
Right. I mean, I was going to add that, looking globally, I mean, early in the pandemic, the US sort of stepped back from certain kinds of global leadership positions. There was really pulling back of support of the WHO, pulling back of support of paying attention to what was happening across the world, what countries were really not getting access to testing, all of those kinds of things that, in previous moments, the United States had been taking leadership positions. Those positions, they were pulling back. That's one of the things that happened globally. And in every country, these things get played out differently due to culture, due to economics, due to political structures, all those kinds of things, not to minimize those. But the creation of something like a WHO came about because by the end of the 19th century into the early 20th century, nation states recognized that certainly with the case of infectious diseases, there are no borders. It's going to travel wherever it can find hosts. That's what viruses do. That's how they survive and live to strike again. And so they realized they had to talk to each other. They realized they had to share best practices. They realized they had to think about what it meant globally to think about issues of sanitation, of preventative aspects of healthcare. And so people began meeting, and you get structures like in institutions like WHO. Many people have great criticism of the WHO. I'm not dealing with that, but I'm just saying the impetus was we had to work together. I think that stumbled a bit early on in this pandemic. And what emerged out of that was increasing distrust of institutions like the WHO, increasing distrust of institutions like in domestically, like the CDC and other kinds of people and people who were leaders who had certain kinds of expertise. Putting that distrust emerged so early in the pandemic, and it set the stage for so much difficulty that we continue to face even now, as the goal right now is to get as many people vaccinated as possible. And a lot of the people, and now we have a whole range of people who don't want to get vaccinated because they don't trust what they're hearing. They don't trust what's on social media. They don't trust institutional leaders. They are, they don't like the fact that the information continues to change about what we should and should not do to protect ourselves. They want a certainty in response that cannot exist if we live with a virus that is changing as we in response to things that we do. And so we never were able to set the stage for the whole country to be able to understand clearly, without political ideological slants being put at the center of it, what this virus is, what we know, what we don't know. This is what we need to do right now, but we may need to change next week.
Yeah,
because we're going to know something different. And right now, a lot of people are thinking, well, it's all over. This is just vaccination time. Yep. No, there's still a lot of questions about what might happen. And we still need to be paying attention to trusted experts at a moment when there's question marks over the head of every institution who is charged to provide information to the American public. There's a big red question mark on it because we've been through this whole period where there's been a really assault on expertise. And that's
this is such an important point, I think, and it's one that so many of us can relate to because we're hearing one message from state governments and we're getting news reports coming out of CDC and WHO. Can you, since you brought it up, Evelynn, can you speak to how we might begin to repair some of the damage that's been done when we're talking about the breakdown of trust?
Right.
Goodness, if you could solve the problem, I'm sure that you would solve it by yourself. But I mean, I'm just asking you to kind of think imaginatively. You could even go back in time to the beginning, right? Pretend you had a time machine and go back and say, this is what we should have done in the very beginning. And we wouldn't be at the place where we are now when it comes to this issue of dissatisfaction with political communication, trust, messaging. Help us get to a better place here.
So I'll just make one historical point. We already knew that many communities of color had long histories of doubting and mistrusting officials in public health and medicine. I have a whole office full of books about this. We knew that. So we could have started by recognizing that was a historical problem and immediately speak to it instead of waiting to see, oh, it emerged. It didn't just emerge. Everybody knew this. We knew that, for example, if you take Massachusetts, for example, we could have told you what communities were going to be hit hard pretty much. Right, based on what the bits and pieces we were knowing, we knew communities of color where people lived in under certain kind of environmental and social and economic conditions that we need to pay attention. We need to pay attention right then and there to that and speak to it. But that didn't happen That didn't happen because it wasn't based on that perspective, right? And so I also think that we could have spoken more quickly and in one voice about the need to really trust the evidence and get as much good evidence as we possibly could. But it also meant that political leaders and public health and medical leaders had to look carefully at the context. If you know that right now in the middle of Alabama, if someone who has to get their HIV medication has to take 2 buses and 3 taxis and blah, blah, to get their HIV medication, then you know it's going to be hard for them to get medication and testing and support for COVID. You know that already. So why not act on that kind of knowledge that really, what I would say is really spoke to the structural inequalities that we knew were there, as opposed to acting as if all these things would be new, as a surprise, that the fragmentation of our systems was a surprise, all of those things. And I just keep coming back to that because I think it would have been possible to do this differently. We could have communicated differently and better had many people who had the expertise and the knowledge and the perspective work together. I think one of the best things that has happened is that in communities of color, for example, since we have many more practitioners of color in public health and in medicine, just started acting on their own. The young woman in Philadelphia who just said, got a van, we're just going to get in the van, we're just going to go into the community and start testing people. We are going to do it. But that's not new. In the 1940s, the Alpha Kappa Alpha sorority did the same thing in the American South, because they knew that those people in the South weren't getting any health care. So they piled stuff in a car and went traveling through rural Alabama. We know those stories. And as people acted on that kind of insight recently in this current pandemic, I thought that was a very important set of actions that could have been made more prominent and spoke to when we have the kind of structural failures that we've had. There are still ways for people to be reached who need help. And those kind of ways, like getting in a van and taking it to the people, taking whatever needs to be taken to the people to bring this under control, is something we've always tried to do. And I think we should have recognized that we would needed to be ready to do it. So that's my perspective on it. We could have really paid attention to those things and been more proactive early on in the pandemic.
Great, thank you. Nancy, go ahead.
What Evelynn is saying is that I was involved with one of the groups that I lead caucus within the American Public Health Association, Spirit of 1848. We worked with Public Health Awaken to create this real-time list of resources that were happening around mutual aid all over the country, real-time on the web, because people were doing things. They were doing things about people who were incarcerated. They were doing things about people who were homeless. They were doing things about food insecurity. They were tending to these different issues that they saw were being neglected. And it comes back to this fundamental notion that public health is not only public health, it's collective health. And that's a phrase that gets used a lot in Brazil, which makes it all the more horrific about how
yes,
as such has been undermined in Brazil. But part of the reason that collective health came about as a phrase and as a way of organizing public health there was because it was coined when it was under an authoritarian military dictatorship, and you couldn't trust the state. The state was actually on the side of killing people, not actually protecting people. So government is, it's not just that you should have government, you need to have the right kind of government, a government that stands up for public health, for health equity, because you can also have governments that do very bad things and really harm health and health equity. So from that standpoint, that was what was needed. The knowledge that the need for collective health action, particularly for communities who have good reason to have doubt about whether the government is actually on their side or not. Combine that with everything that was going on before George Floyd was murdered by the police, add then that particular egregious murder on top of the others that happened with police killing people in the US 3 times a day. And it's been that way since the statistics started getting reasonably gathered, starting in the mid-2015 or so. So I think that needs to be, again, put in perspective, and that there's been incredible collective action that has been done by different groups in different cities. But it's, again, as Evelynn has pointed out, it's a known that would be needed. It's not a surprise. Why couldn't that be funded?
Yeah. One of the other, and thank you for that. One of the other questions that's bugged me is how this pandemic is going to affect the way we talk about health and healthcare as political issues. It seems to me, this is just my impression, when we debate these things in the public sphere, healthcare gets talked about in terms of cost, individual choice, freedom of choice in the marketplace. And yet what you all are talking about, collective action, community health, public health, seems to me to be a much more wide-reaching and potentially exciting way to think about what the politics of health actually is. Mm-hmm. So Nancy, given that there's really nobody better to talk to about this than you, I wonder if you could say a few things about how we could enrich our conversation by bringing a public health lens to the way we traditionally think about health, or discuss health, at least in American politics. Can you help us out here?
Sure. I mean, so I want to caution that even the usual binary, and of course we are at a position of questioning binaries, of public health versus healthcare, public health versus medicine is problematic, because find that, you have to step behind each one and ask, does it have a biomedical individualistic orientation that's premised also on notions of essentialist biology and people's behaviors being a matter of their personal choice? Or do you actually take, and this can happen in medicine as well as in what gets called public health, a view that understands that people produce health and they produce disease, and they do so with differing amounts of power and different amounts of ability to respond and to shape the context in which they live and which they work and which they ail and which they die. So if you think about, for example, the first community health centers set up both here and in Mississippi, they were premised around community empowerment. And they were just about, and that involved training people in the communities and helping with the education, but also dealing with sanitation, dealing with food insecurity, dealing with housing, dealing with all kinds of things, and seeing health is something that is collectively produced and can also be socially harmed. So I think that the key thing is understanding that there is a chance with public health to have a much more integrative approach if it's that part of public health and not the part that also has had its history of being very individualistic and victim blaming and telling you to just behave better. And it's like, you could say, fine, self-isolate, but then where? Where are you going to self-isolate? So if you don't address the material conditions in which people live and the economic constraints on how they live, you're never going to end up solving what the actual public health problems are. So I think that it creates an opportunity, which is one of the things that's very exciting, for so many more alliances. And I have seen people connecting the dots across so many different movements. The urban planners that get it in relation to COVID, they're all into the public health. The climate change people making the connections, environmental destruction, climate justice, environmental justice, making the connections. What happens if you've got asthma? What does that do around COVID risk? You're seeing through this lens of the ways in which our bodies could frankly give a fig about how people decide intellectually to cleave up issues. They're integrating them all the time. And I'm starting to see different sectors of civil society and also government agencies now with the new administration behind that, also linking the issues in ways that makes for more possibilities for more effective change collectively.
I would just add one thing to this. As I said, pandemics reveal inequalities. I think now people can see, because of what we have lived through, over 600,000 people dying, they can begin to see what many people have tried to talk about in terms of the inequities of our healthcare system and the fact that employer-based healthcare, and see the ways in which it cracked during this pandemic and continues to crack. And now people have a real sense of it. They couldn't go to work, many people being laid off, and they had no healthcare. Right? So what has been studied through in the United States, certainly since World War II, about what kind of system do we need to bring up the whole health status of the United States, people in the United States, is now, I think, quite concrete and real in the lived experience. People have families. One person in the family might be doing very well and had health care last June, but people have extended families and somebody else didn't. And you can see it now. People can feel it now. You don't have to read different issues of health affairs or economic tomes that tell you all about it. People are living what our system, the cracks in our system. And I think that's really important, that we take advantage of the fact that people have more basic understanding of what we need for all of us to do better in the face of pandemic disease.
And just to add one more point to build on the critical points that Evelynn is raising, is the other thing that people have witnessed is that actually when government focuses on doing something, government can. Look at the vaccine production, and also that government can make regulations. When we're coming out of this period where the framing of, since the 80s, government is the problem, government should just get out of the way. It's like, no, if government gets out of the way and you have a pandemic, you have like a lot of dead people. And then you don't exactly have a society. And then even the people that are, I'll spare what's gone on with the number of billionaires that have increased during this pandemic, because there's a whole other piece of that conversation. But the idea that you can actually have government and government can do something, and not only can, it must, to actually address the health of the public. I think that's one of the things that's really come out. And it's not just to oppose government is bad and makes a mask mandate. It's actually how government helps people thrive.
Great. I think that's a really important message to deliver. This is the point in the conversation when I want to remind our audience that the Q&A function is open if you have things you want to add or suggest for our panelists to discuss. And one of the things that's already been popped in there is a question about the role of digital technology in the story that's playing out today. And we've talked a little bit about the kind of crisis in communications that we've had. And I think that that's maybe one part of the discussion, the role digital technology plays in messaging, framing, and communicating. But then I think there's a whole other piece that this opens up around the potential for digital technology to help us with things like tracking, sending us alerts, things of that nature. So do any of these things kind of pique your interest when you think about the ways digital technology has influenced our experience of the pandemic? Evelynn, I see you nodding your head.
Yeah, I mean, it has, but I do think it's there's at least two pieces of it that we ought to be paying attention to. If digital technologies can help enable collection of our health information in a speedier way that helps informs policy decisions or even just basic medical decisions, I think that's really positive. Except then, if we're gonna go down that road, then it has to be for everybody. Yeah. Then the digital divide that we have lived in, where you're hearing people talk about working remotely and having telemedicine visits with their primary care physicians. Well, the people who don't have primary care physicians are also many of the people who do not have computers in their home, access to broadband, and therefore cannot do that. So if we move quickly into digitizing and using digital technology to increase the amount of medical information we can get from individuals without paying any attention to the fact that there's a serious digital divide in this country, and that means that other people will not be able to do so. We had kids this year who were sitting outside of libraries that they could not get into, but the fact that some of those libraries were hotspots in order to do their homework, right? So you want to do that when it's time for them to think about, how do people get their immunizations and where are the records and how do you do that? We have to, if we're going to bring those tools in, and I think some of them are very, give us a lot better access to information that we need, but then we have to be really serious about this has got to be for everybody.
And the other thing that I would add is that also because we know the context that we're in, having data people who really understand privacy and understand also the steps that need to be taken to deal with the outright lies. I mean, you could politely call it disinformation that is being still circulated. That's got to be a part of it. That also can't be an afterthought. There's too much that people know about how privacy is violated and where the data is going to end up and who's going to keep track of it. And tracking people in the United States context, I mean, it's very different than perhaps some of the initial tracking work that was done. For example, early on when tracking made a difference because there wasn't infection everywhere in South Korea that people will talk about. It's one thing when you have a handful of people and you're doing contact tracing. When you've got it widespread through the population, contact tracing is not anymore and tracking people is intrusive. So understanding where the privacy part comes in, who controls the data, and is anybody making money off the data, and how does that distort it, as well as who's lying with the data or the digital technologies also has to be part of the picture.
Great, thank you. Can we talk a little bit more about vaccine delivery? There's a question in the chat about that as well. Each of you have already mentioned the efforts that folks have taken up on their own, really, to bring the vaccine to communities that are underserved. And as wonderful and desperately needed as those efforts are, I have to believe there are other things that the government or other agencies, institutions can do to improve vaccine delivery and reduce some of the inequities we've seen when it comes to that particular issue. Do you have any more thoughts beyond what you've already said about specifically around vaccine delivery and reducing some of those inequalities? Either one of you could jump in on this.
Yeah, I look at this. I mean, my first book is about the control of diphtheria in New York City. 1880s to the 1930s, and it was one of diphtheria is a very virulent disease that killed a lot of children under the age of 5 and from the 18th century throughout the 19th century and into the 20th century. Now, one of the reasons we don't see a lot of diphtheria anymore, because in the US, there's a very serious requirement that young children get vaccinated, immunized against diphtheria before they can go to school. If we stop doing that, we would see diphtheria, right? And you don't want to see that because children die from it. People die from it. It's a very virulent disease. So the campaign that started in New York City, and I'll be brief about this, they recognized that in order to bring it under control, you had to reach everybody. They had sermons in every religious institution in New York City promoted getting children immunized. They had notices about the value of immunization in every spoken language in New York City in the 1920s. They had politicians speaking about it. They have civic leaders speaking about it. You got a notice about it in your electric bill. It was clear that you had to get to everybody. And you had to bring everybody along, not let some people opt out. Now, some people, of course, did the people who wanted to opt out, were they angry and felt like their rights were being stepped on? Of course they were, just like now. Or were there people who were suspicious of the immunizations? Were there people who had side effects from them? All of those things were true. All of those things happened. But at that time, using a bit of more of the sort of force of political leadership, in New York City, they said, we're not paying attention to that when you're going to do it anyway. And so, but, and then they called it a success. I'm not advocating using that kind of public health authority right now, but I do think that we need a much more concerted one voice. I think some of the media is still in a little bit of both-siderism. Yeah, well, some people, you can expect that I think that time is over. I think the time is now. What can we do to reach everybody? What can everybody do to help reach the people who don't feel okay about this? We need to be focused on getting it done. And I'm not trying to dismiss people's fears or concerns, but I think we need to be in a much more collective voice saying, this is the thing we need to do right now, and this will allow us to keep our society open and keep people safe and alive. And so I think still there are too many voices out there being communicated, right? Every day you hear a little piece about this on one news program, something else on social media, something else in what you read. And it's sort of this sort of chaotic sense of it. At least that's my experience of it right now. I pick who I think are trusted voices. And I try to tell people I know, no, you shouldn't look at that. You should only pay attention to this. But I shouldn't have to say that. I think we need a lot more of a sense that every opinion is not one that needs to be broadcast widely. We need to have a little bit more focus and a lot more sense of that. We absolutely no equivocation on the fact that we need to do this to save everybody.
Nancy, anything on this one, or should we move on to?
Yeah, I'll just quickly add, I completely agree. It's the one voice, but also with the knowledge that you have to communicate that message tailored to the different groups.
Exactly, yes.
What you say about young adults who are not used to being told they have to get a vaccine because they never get a flu shot even at this point. What you say to people that age is going to be different than what you say to people above age 65. What you say, what's going to happen also, which we're going to see play out more, is what are the policies that schools play, whether at the K through 12 level, depending when the vaccine becomes available for everyone at those levels as well, through all the grades, not just the teens, but also what's happening at colleges, but also what's happening at workplaces. And then that gets back to the question of what we're also going to see is litigation that's inevitably going to continue about if people try to, if workplaces try to set a vaccination requirement with, again, understanding of religious and medical exemption, how's that going to happen? But that is only going to play out if government all the different levels is doing what Evelynn is saying, and government is giving the voice, and government is funding the different groups that can get things out in all the gazillion languages that it needs to be gotten out in, with the right kinds of messages that appeal to different communities, some about their own health because they are older and more vulnerable in that way, some about taking care of the loved ones in their lives, which is a different kind of motivation than just their own personal health. So, and there's so much with what's gone on in social media and in health communications that those kinds of tailoring behind the fundamental message that Evelynn was describing is completely reasonable to expect.
Yes, absolutely.
I think we've got time for one more question, if I can be greedy here, and it's one that just popped up in the chat about, how we might take where we are and look forward. We can't anticipate what the next pandemic might be, but certainly we've learned some critical lessons from our experience that we're currently going through. What are the one or two things that we absolutely need to hold on to from right now that will allow us to be better prepared to face something similar to this in the future? I know it's hard to whittle it down to one or two things, but whatever you're kind of feeling most strongly right now, given the conversation that we've had, not only when it comes to inequities, but also just some of the logistical data collection stuff that we began with. I mean, what do you really want us to hold on to as we face whatever lies ahead?
When years ago, there was a wonderful article published about in the early parts of the 20th century about public health, where public health experts started saying germs know no color line. If we can learn anything out of this, is that we are one community. We really have to think about this, step back, as Nancy also said, step back from focusing on individuals and start focusing on what has to happen for communities. That message needs to be tailored for all the different groups that Nancy just spoke about. And for people to really, this just has to become as fundamental a premise as anything else we do as Americans, right? It's got to be up there with the right to vote. And when it comes to health, we have to talk about it as if we are really a community, because we are, because if you can't bring us from the brink of this kind of pandemic back to some kind of health without everybody's commitment to that. And that's the one thing that I would like to see. I don't want to see this fragmentation again. I want to see people pay attention to the fact that as a community, we have to stand together. And that means we have to fund public health. We have to fund preventative medicine. We have to fund provide all the kind of resources that provide care to vulnerable communities. We have to do that. It's no longer an option. There will be something else like COVID. And if we're going to be ready for it, we have to bring that mindset to do it.
Nancy.
I underscore those points. And I think, but also to speak to your data point that ties back as well to what Evelynn was saying, is a principle would be that health equity is at every single place in any pandemic response, from the first moment of collecting data and ensuring the data get out to the last moment of taking care of people, especially when they have their last breaths. So the whole thing has to have health equity at the core, asking those questions that are framed from the standpoint, because again, equity in health refers to those things or inequities, which are in principle avoidable, could be prevented, and are unjust. So you have to cover all three bases, and they could be, and that's absolutely played out in this pandemic. There was, remember, a pandemic preparedness plan that came out under the prior administration, got thrown out the window. And here in Massachusetts, there was a pandemic preparedness plan that built off of all the work with funding to it that went from since 9/11, which again got dumped in favor of doing private-public partnerships, which is a particular mode of governance. They left out the public health. And even now there's fighting in the Massachusetts legislature with the governor about whether the federal funds that are coming in, will they be allocated properly to public health, because it's so underfunded. And it's being pit now as a fight between that, for example, and housing, which is also clearly important. But it's like, if we don't both have a principle of health equity and B, fiscally, structurally look at what the state of the health departments are and the health workforce in public health to make these things happen, we're going to be not prepared.
Right.
Well, I think that's as good a place as any to land. I really want to thank you both for your time, for your insight, and for all your work. Honestly, we need you. We need you now, and we're so grateful for the unseen labor that you've put in to drive what we can only hope will be substantial progress on these issues. So with that, I'll kick it back over to our hosts and just thank you one more time.
Thank you, Michael.
Thank you very much for moderating as you have.
Thank you, Michael, Evelynn, and Nancy, and thanks to all of you who joined us today. We hope you'll join us for our next signature event. Our next signature event is scheduled for Tuesday, July 13th with Professor Sarah Bleck and Erica Kenny. They will be talking about addressing food and nutrition insecurity during the pandemic and beyond. Information on an upcoming event, as well as recordings of past ones, can be found at vpal.harvard.edu/vpal-events. Good night, everyone. Thank you for taking the time.